Okay, so welcome back, both in the room and online. Great to have you all. I think we had a great kickoff to the event. I think the rest of the day is going to be equally engaging and exciting. So we'll be moving on to the second session of the day now, which will be looking at the potential drivers of relapse, specifically examining trends in seasonality and geospatial patterns. Again, let me invite our speakers up front. Anastasia Marshak is a research assistant professor at Tufts University. And Amber Dismer is a health scientist at the U.S. Centers for Disease Control. And Mike Mansky is a senior nutrition advisor, I believe, with the Bureau for Humanitarian Assistance. So welcome, you guys. We'll start with the presentations, and then Mike will facilitate the question and answer session. So let's go.
I press this button?
The green one.
The green, oh, the one that, yeah, okay. Well, thank you so much for that introduction. So today I will be presenting on the seasonality of relapse of acute malnutrition. I do warn you, these are very preliminary findings, so we're still expanding this analysis. So first, a little bit about what does the literature say about the seasonality of relapse? Well, first of all, there isn't a lot of literature on the seasonality of relapse. And the literature that does exist tends to point to relapse peaking in what is called the lean season or periods of high food insecurity. And something that we found when looking through this literature is that they tend to look at seasonality in a very categorical approach. It's splitting the year into high food insecurity, low food insecurity, lean season, non-lean season. So it's this very categorical approach. The other thing that I hope you see here is kind of the bias that is introduced in the language that we use to describe seasons. So just by calling it the period of high food insecurity or the lean season, it means we're imposing this implication that relapse is primarily driven by lack of food. So we wanted to explore this more. And one of the reasons that we think that seasonality is not really looked at so much in relapse is because usually when a time variable is used in relapse studies, it's used to look at round of data collection or number of months after discharge. But as you saw in Heather's and Sarah's previous analysis, there's not really that much of a difference in the risk of a child relapsing across months of discharge. So what is the seasonal pattern across the year? So one of the things that we got very lucky with is that because this was a rolling enrollment, we actually have almost 2 years of data following these children across these 3 contexts. So what we did is we applied a model from the epidemiological literature at how we look at things like flu and COVID. And I just want to point out a couple of things that make this model a unique approach for looking at relapse. First of all, it treats time as a continuous variable as opposed to a categorical one, because we have that data from our digital data gathering approaches. Second, it specifically looks at the most granular form of time. It looks at day of data collection as opposed to month, because we know that relapse and wasting can change over a very short period of time. And finally, we don't impose the assumption of just one peak on this model. We test for multiple peaks because we want to see if that is a possibility in these contexts. So what did we find? I'm going to go by it through context by context. So in Mali, we identified actually 2 seasonal peaks, one at the start of a rainy season and one at the end of a rainy season. And that same pattern was repeated across both years. But what I want to draw your particular attention to is that during the rainy season itself, the actual relapse, it doesn't go down by much, but it does go down, or more importantly, it doesn't go up. So while food insecurity is actually increasing, we do not see an increase in the risk of relapse. And then generally from that, we see that, yes, relapse rates are really low right at the end of a harvest period, and they climb during the dry season itself. So the other thing I want you to note is the difference between the worst time of year and the best time of year, particularly in 21, it's huge. We're talking about a 10 percentage point difference between those periods. So next I want you to look at South Sudan. In South Sudan, we have a model that looks a little bit more as what is described in the literature. We see the risk of the prevalence of relapse increasing during the dry season, peaking at the end of a rainy season, right before the harvest period. But what makes South Sudan a little bit different from what we see in Mali is that you see that, first of all, the prevalence of relapse never drops below 10%, as opposed to Mali, where we did actually get quite low during that January period. So the amplitude of the worst time and the best time is much smaller in South Sudan than it is in Mali. And what's interesting is that when we did this analysis for acute malnutrition for another study at Tufts, we found the same thing in South Sudan in terms of acute malnutrition versus its neighbors. The amplitude of acute malnutrition was very small between the worst time of year and the best time of year, and it never went below 10%. And so we think that is very context specific, in South Sudan being a particularly vulnerable context with constant levels of some conflict. Now, in Somalia, I do have to remind you of a context again. We're talking about an urban IDP setting. So we never really expected to see much seasonality here, because if you look at other indicators that generally do behave seasonally, you tend to not pick that up in IDP settings. The model did pick up on a little bit of seasonality, different from the other two contexts, where the peak is actually during the dry season as opposed to the rainy season. But again, the general seasonality is quite low here, so I think we would have to be very careful with treating these as results. So what I want to talk about next is kind of how the seasonality of relapse compares to the seasonality of acute malnutrition more broadly. So we just published recently this analysis of 500,000 observations from 20 years of SMART survey data across the entire drylands area with one main rainy season. And I want to draw your attention to the fact that there are very clearly two peaks, corresponding more to the Mali example. We have a peak that happens before the rainy season starts, at the end of a dry season. Then we actually see acute malnutrition going down during the rainy season while food insecurity is increasing, and then the secondary peak before the harvest. So I think we do have to be really careful about thinking what all of the possible drivers are, and thinking about what those drivers might look different at one time of year, such as the end of a dry season, as opposed to right before the harvest. And so be a little bit more careful than kind of generalizing about food security more broadly. So what does this all mean for us? Well, first of all, it does mean that when we think about any kind of programming approach to address or prevent relapse, surge model, community screening, follow-up visits, they really need to be temporally timed. So all of these models, other than Somalia, really point to the fact that we need to start thinking about this in the dry season as opposed to focusing specifically on the rainy season. We do see that there is this pattern, especially with relapse, more of an acute malnutrition that follows food insecurity, but it is much more nuanced and more complex than that. And so we really do need to be thinking about what those drivers look like during the dry season, and they're likely not only food security, given that we're not seeing that increase during the rainy season itself in Mali. And finally, we need to think about the fact that, yes, in IDP camps, we probably have very limited seasonality. That's most likely the case, and that kind of corresponds with our theoretical thinking around it. Of course, I like methods, so there are methodological implications that I think are just as important. So one of them, we really should use more participatory methods to really understand what the seasons are, as opposed to treating them in these 2 or 3 categories. For example, in India, there are like 15 seasons in certain areas that are specifically tied to access to natural resource and livelihoods. In this area of the Sahel, there's generally 5 seasons, with a particularly short season at the end of a dry season, beginning of a rains called Rushash, that everyone identifies as really period of high vulnerability. So we need to look at that more carefully. We collect all of our data on digital devices now, which means we have a precise day when data is being collected. We should utilize that granular data when we can. And avoid categorical terms as much as possible in our models, because they're just not as good. And finally, from a research perspective, I hope what comes out to you really strongly is that there are consistent seasonal patterns in relapse. It is not the same at every time of year. And that those seasonal patterns, particularly in a place of Mali, we're talking about huge difference in relapse across those periods. And what that indicates, and as you'll see with a later presentation, is that individual and household level variables might not be the main thing here. We might really need to be looking at community level drivers and these basic causes, because they probably do a much, well, we hope our data shows, they do a much better job at predicting relapse than individual characteristics. And we'll talk about this more in a later presentation. So thank you very much, and I look forward to your questions.
So thank you so much for having me here today. My name is Amber Dismer, and I'm a GIS specialist at CDC in the Global Health Center, focused on humanitarian populations. Steve Scroggins isn't with us today, but he is online, and he is a GIS specialist at our Geospatial Research Analysis and Services program. And we're really excited to show you how we can use GIS to predict geospatially where children are more likely to relapse in a community. So these 4 maps here highlight environmental and structural variables that we evaluated in predicting relapse for South Sudan. Here you can see that the density of water in blue, the elevation in the community in green, the density of roads in orange, and the combined drought index in red. Overlaid on all of these are the nutrition sites in yellow. So let's dive in, though, to what the data was used to predict relapse. In each of these 3 countries, we use the GPS coordinates of kids from the households that were taken at enrollment in the 3rd month of follow-up and at the 6th month of follow-up. It was really helpful to have all 3 GPS readings because it meant we could use the readings with the best accuracy. Second, we used if the child had ever relapsed across the time period as our outcome of interest. On the left here, you can see all of the other environmental variables and structural variables that we considered. Up top are the structural variables, so the nutrition sites, the roads, and the service areas. And below, you have the combined drought index. And this is only available for East Africa, but it includes rainfall, soil moisture, and vegetation conditions. In Mali, we looked at all of these other environmental variables separately. So let's dive into Mali. This map shows you the Mali study area with the nutrition sites in yellow and the major roads. The purple lines that you can see are actually the surrounding service areas at 3 kilometers, 5 kilometers, 10, and 17 kilometers from the service areas. To protect the household locations themselves of the children in the study, a surface was generated to show the density of children per cell, with blue indicating a low or no household in the area, to red indicating the highest density of children in the study area. So you can see here that the highest number of children was in Kai Town with the 4 nutrition sites. Next, you can see here the density of children who actually relapsed in the study. That's aggregated to cells that were 3.4 by 3.4 kilometers. So what you should see is that the red cells indicate a higher density of relapse, and then the light yellow shows the lower density of relapse. And this surface was used as the outcome of interest in the models. So let's look at one of the models. We found that overall the best model type was a binomial generalized linear model. So out of all the possible environmental variables that I had showed you a few slides back, rivers and roads were highly important for predicting where children will relapse in Mali. This table on the left shows you the estimates, z-scores, and the significance of those estimates. But what this means is that 1, the farther away from rivers, the lower the likelihood of relapse of kids, and the farther away from the roads, the higher the likelihood of relapse. So this is what we expect in terms of roads, but a very interesting results in terms of rivers. This map shows you, in blue though, all of the locations where there's a high density of rivers in our study. And you can see a lot of rivers in the main city of Kai, where the highest density of children were located, and we had the higher density of relapse. And then also there's many rivers in all of the sites except for Sadiola in the southwest. In red, you can see the predicted probability of relapse. So even though we only had the data of the children attending the sites, we predicted relapse for the entire study area. And higher relapse rates were predicted near the town of Kai, south of Diamu, and south of the 2 sites in the northeast. So let's move to South Sudan. And again, in South Sudan, there's 44% of the children accessing the nutrition sites lived more than 5 kilometers from a nutrition site. That's very different than these other areas. In the northern area here, you can see that there's 5 nutrition sites, some with overlapping service areas. Here is the density of children who relapsed in the study area, aggregated to cells that are 2.3 by 2.3 kilometers. And what's important about this is, first you can see that the northern sites had a higher density of relapse than Gabat in the south, because you can see there's darker red values. And second, the relapse density was high in areas that extended past those 5-kilometer service areas in the north, especially in the central area and eastern areas. So for South Sudan, we excluded children that lived greater than the 10 kilometers from a nutrition site. And here, the important environmental variables were elevation and this combined drought index. Essentially, the higher the elevation, the lower the likelihood of relapse. And this is likely because the higher elevation areas were closer to Gabat, which had the lower relapse rates. And second, the average combined drought index, it wasn't statistically significant, so there's no asterisk near it in our model, but it did contribute to the overall performance. So this is why we kept it in the model. All right, this map shows you the probability of relapse with the highest locations in dark red. It was generated using a Kriging technique, as the model's residuals were spatially autocorrelated. And again, you can see the urban site in Gabat has a very low probability of relapse, whereas the sites in the north have a higher probability of relapse, with many at greater than 60%. In Somalia, the Kata nutrition site was located in an urban city center, as already mentioned, and it had high accessibility to residential roads, primarily serving IDPs. Planned settlements of Kura and Bilan, which you can see here are the triangles. The scale for the service areas is tighter, as 94% of the kids lived within 3 kilometers of this site. And the highest density of kids is a little bit to the southeast of the main site. In Somalia, a very low percentage of children relapsed. This map shows you where the density of relapse looks like, and the surface only covers a small area. In our Somalia model, the only important variable was the distance to the roads. The closer a child lives to the road, the higher the likelihood of relapse. This might not be what one would expect, but again, remember, this area has a really high density of roads. And overall, even we want you to remember that this model is still better than if you were just randomly guessing. So, again, remember that although we had very low relapse rates, the probability of predicting relapse for an area was no higher than 7%. So this is very different than those other 2 maps I showed you. This does show us that the areas of southeast of Kata and north central have a higher probability of relapse. And given that this site primarily serves IDPs, this should only be used for this area. You wouldn't necessarily take this model and apply it to other populations, even within this area. So then we were very interested and curious and wanted to further explore the distance to nutrition sites. Our question was, do we see a difference in the outcomes of sustained recovery and relapse based only on a distance from nutrition site? In short, no. None of the p-values here are statistically significant. Now, this analysis doesn't detect a difference between distance from a site and relapse outcomes. We do see, though, in Mali, and more so in South Sudan, the very high percentages of kids accessing care that are further from the sites. So, Overall, it's very exciting that we can predict where children will relapse in a community using environmental variables and study data, and these prediction rasters are now available for the 3 countries. There's a lot we can do together. And second, here are the specific takeaways for each of the countries. In Mali, the distance from a road increased the likelihood of relapse, and children closer to a river had higher likelihood of relapse. And this may be due to a lower accessibility of the nutrition sites or an increased susceptibility to flooding in the area, and the area did have flooding. And we didn't have a combined drought index for Mali, which we wish we had. In South Sudan, children at lower elevations had a higher likelihoods of relapse, and the higher the average CDI, the more likely the children were to relapse. In Somalia, again, children that were closer to roads were more likely to relapse, but we can predict where relapse will occur, even though we had a very low relapse rate. The models are still better than guessing. And so, so with that, we'd like to say thank you very much.
Okay. Oops. What does this do? It's a clicker. Thank you so much. I'm just so great with technology. Yeah, so just the reason why it took me a while to come up here, I was just immersed in thinking about the implications for your studies. Thank you so much, Anastasia and Amber. Really appreciated to learn about 3 countries, in particular, one country where I've spent quite a bit of time, which is Mali. And so to kick off the Q&A session, I actually had a question of my own, if that's okay. And either of you can answer how you may like. So one of the things that I kept thinking about when you were comparing Mali to South Sudan, and I think Somalia is IDP camps, so maybe not as relevant, but I kept thinking about the livelihoods are very different throughout the countries. So for example, in Mali, and I know where we have a lot of emergency programming, they're more pastoralist, or it's just a question I have, whether that's something you were taking into account or thinking about, and whether you think it's important with regards to these kind of contextual considerations.
Yeah, absolutely. Hello. Okay. Absolutely. So we know that in K's, I believe, in Mali, it's a pretty mixed livelihood system, right, where you have some agriculture and some pastoralism as well. So certainly milk access probably does play part of the story, because we know that milk access is at its worst at the end of a dry season, and then it tends to improve during the rains from animal production. But it still wouldn't explain fully why we're not seeing this increase that's happening during the rains, because it just still takes a couple of months for the animals to actually give birth and then produce the milk. So we do think it's absolutely part of the story, is thinking about the different livelihood systems in terms of milk access versus cereal access, but also there's probably something else in the dry season going on in terms of additional vulnerability, the care practices, the less time available, lower access to water.
Right.
It's part of the story, and it definitely has to be considered within the livelihood profile, but I think there's also more to that than that, but absolutely. Mm-hmm.
Yeah.
Oh, I do want to actually, if it's okay, can I add one more thing?
Sure.
So in relation, it actually plays really into what you found in terms of the proximity to the rivers, because we did also see this in a study that FAO did in Western Chad, which is a primarily pastoralist community.
Right.
And when they were looking at the relationship to acute malnutrition, not relapse, they found that the closer you were to a river, the much higher the risk of a child being acutely malnourished. And some of the hypotheses coming out of Chad from additional work in Eastern Chad, that it does have to do with water and the interaction between water and livestock. So the closer you are to a seasonal river, the more livestock you tend to own in the first place, because you have access to the natural resource. The more livestock are migrating through the area as well, the more you're likely to rely on those river sources if a borehole breaks instead of fixing fixing it right away. So I think the interaction with livestock in particular is highly relevant for both for relapse and the acute malnutrition story.
Wow. Great. No, that's great. No, it's something I'm interested in, so it was great. I'm sure many others too. Did you care to comment, Amber?
I just wanted to add that there were a number of kids in Mali that we noticed they moved around during the study. So this was another reason, like we initially saw them in Kai in the center of the town, but then they moved, and that's why taking the GPS points multiple times, not just the first time, was really important.
Okay. Great. So what we're going to do now is take some questions from the room and then hopefully intersperse questions coming from online. So I think we can start. If there are any questions in the room, please raise your hand. I thought there might be some WASH questions about the rivers. I'm not trying to prompt you. I was going to, but it wouldn't have been very eloquent. So, and please state your name and your organization. And I think the first hand was from, you may go ahead, Lauren.
Fantastic. Thank you. I'm Lauren from the London School of Hygiene and Tropical Medicine, and I'll be presenting on the WASH risk factors later. But this is just to add, actually, to the presentations. And this is more first on Amber's point with the combined drought index. And we will talk about this a little bit later. But we also saw, not a significant, but an association with water insecurity in the setting, in South Sudan specifically. And so it's really aligning those two results together, that there is that interplay with that increased risk of relapse that we're seeing. And then I'm going to also add something to Anna's presentation. Similarly, we will present this later in a little bit more detail. We looked at animal ownership within the WASH kind of sub-study to really look at kind of the exposures environmentally, and we saw kind of, I'm going to beat myself to the point here, but a reduction in the risk of relapse from cattle ownership. And there is that seasonal pattern that we see from kind of some of these trends coming through in the data. So it's really great to see kind of us looking at it from different angles, that there is this really big mix of interplay of factors that are coming together with increasing or reducing that risk of relapse. It's not really a question.
We'll take one more question in the room. Please.
Hi, Lieven Hubricht, Safepre. I was wondering, I adore these charts, obviously. They're really nice, but they always raise more questions. And to what extent are you planning, or did you already unpack some of the differences of these households? For instance, are there socioeconomic gradients from people living near a river? Maybe these are the plots of land that are not really desired because they're flooding, and etc. Or any other determinants. Do you already have some insights there, or are you planning to unpack this?
Excellent question. This is something that, from the geospatial perspective, we're just starting to look at. So we have not unpacked it. We just looked at those environmental factors. But possibly, and
Don't give the results.
Not going to give you the results. You'll have to wait till this afternoon.
So,
but we do talk about wealth and food security.
I was wondering if we may take a question online, please.
Yes, thank you. We do have a lot of questions online about these household characteristics, so stay tuned. That is coming. For now, I have one question for Anna and one for Amber. So for Anna, could you talk about the difference in relapse between seasons? Are these differences in the risk ratio between post-SAM versus control children, or just pure relapse incidence, which might be similar to malnutrition incidence overall? And then for Amber, this is a very technical question. I'm interested in the overall fit of your geospatial models. For example, in Mali, the distance from roads and rivers had coefficients that were highly significant, but the effect sizes looked small. Roughly what percentage of the overall variability of relapse rates did your model account for? It's not clear.
So we do have those numbers, but my co-presenter Steve ran those models, and so I'm very. Please contact us, and he's potentially also he is online. Steve, please feel free to write that answer into the chat if you have it handy. But it is a follow-up question, I think.
Thank you. That was an excellent question. So these are particularly specifically for the post-SAM group relapse, but they do look really similar to the patterns of acute malnutrition. It's not exactly the same. That first peak looks quite different for acute malnutrition versus relapse, but certainly I think thinking about the risk factors for relapse and the risk factors of acute malnutrition, we should be considering them together, both from a preventive standpoint of relapse and preventive of acute malnutrition, though there are differences that we need to further unpack. Thanks.
So any other questions online? Did Steve get a chance to respond? I don't want to put any pressure on him, and if not, it's okay.
He might be typing away.
Okay, that's fine.
Maybe just if you could clarify, there's a lot of questions about this issue about proximity to rivers. People are wondering if it might be due to contaminated water sources or potential malaria zones. If there's any other information on these dynamics you might be able to allude to.
Okay. So maybe, can I go back to the slide that
Sure,
has
I think this is the thing. Yeah.
Okay, so back. So for Mali, where this was discovered, again, you can really see that the first thing is that there's a lot of rivers. And so the majority of the kids were located up here in the central area of Kai. So they lived near those rivers. And there's rivers all throughout. So that is one of the things that the density of rivers was high, and where there were kids and where the kids relapsed. And so it is likely, sorry, I'm standing. It's likely that is one of the reasons, just having the river there, as Anna had mentioned, is impacts on cattle and livestock, but also the areas that had lower probabilities of relapse, like Sadiola, and all of these other areas weren't really, there weren't as many kids in those areas. And you can see that the density of relapse here that we were using as our predictor outcome, there's very low relapse rates in all of the areas where there's kind of in the center here. So I think that, again, one of it is just how the study was located, where the kids were located, but also that's from that geospatial perspective. But from the diving into all the household characteristics, I'm going to pass it to you, Anna.
So, sorry. Oh, okay. Thankfully, I only have a minute, so I won't take so long. But
2 minutes.
From another study that we did in Chad that was very qualitative and quantitative, we found that communities that were closer to rivers were actually the preferred communities for pastoralists. It was the first land given by the Sultan to his ethnic groups, because that's where you have access to this natural resource for both some irrigated farming across the rivers and this access for your animals. And so what was interesting is that we actually found a lower prevalence of acute malnutrition in communities that were much farther away from the rivers, because they had to invest a lot of money to keep their borehole working. And so they were reliant on those boreholes almost 100% throughout the year, because otherwise they would have to walk multiple kilometers to get water. As opposed to the communities that were closer to the seasonal rivers, if a borehole broke, it was less of an urgency. So what we hypothesize from this work that's coming out both of eastern and western Chad is that both that if you're living next to a river, you are much more likely to be using river water, but you also are much more likely to have more livestock around, which has both the positive effects of animal milk, which we know is super protective, but it might also have these negative effects of zoonotic transmission into the water. So it's just a hypothesis, and Lauren will definitely talk about that more this afternoon. Over.
So I think we have about 30 seconds or so. So I just wanted to thank again the speakers, and I guess we'll wrap up the session. Great job, everybody.